Okay, we have more people joining. I think I'm going to get started and people will come on. So first of all, this webinar, this is Building Resilience with Mindfulness-Based Biofeedback. And any questions you have, put those in the Q&A, and I will be looking at that and address that. And I am delighted to introduce our two experts and wave Dr. Sarah Greif. Sarah Greif is a postdoctoral neuropsychology fellow at the Integrated Clinic, and her specialty is neuropsychological assessment and rehabilitation of children, adolescents, adults, and older adults with cognitive concerns. So a lifespan perspective in her training. And she earned her doctoral degree in clinical psychology from the Clinical and Health Psychology program in neuropsychology at University of Florida. And she was a neuropsychology intern at UCLA, my alma mater, yay. And Dr. Lev Gottlieb is a neuropsychologist and UCLA assistant clinical professor who co-founded and manages the Integrative Clinic, which provides team-based assessment and care across the lifespan. And besides developing many very interesting neurotechnologies, he also advises specialized schools, provides forensic testimony, and does research on neurocognition and neuromodulation. And not surprisingly, Dr. Gottlieb earned his BA in psychology from University of Pennsylvania and a PhD in clinical psychology from Northwestern University School of Medicine, completed specialty training in neuropsychology at Children's Hospital of Chicago, NYU Child Study Center, Johns Hopkins University School of Medicine, the Kennedy Krieger Institute, the Help Group, and UCLA, where he continues on the clinical faculty. Whew, there's a lot of
it was a lot. I didn't need all that.
training and expertise in this group here. So I'm inviting people to ask questions. My big question is this model of mind-body resilience. Can you tell me more about that? Everybody knows, mind-body medicine is much better and than biomedical model. Explain to me your model of mind-body resilience.
Of course. Well, many of us are out of sync with our bodies at baseline, and conditions like chronic pain and migraines can really make us feel out of control of our bodies, even more so. Our mindfulness biofeedback is a tool that kind of leverages the mind-body connection to help us gain control and build the skills and habits that support both physiological and psychological resilience. And when you ask what is physiological and psychological resilience, really that's your ability to adapt to novel situations. One of the, I don't want to say the crimes, one of the downfalls of past biofeedback was that you learned about a specific skill and you were good at that skill, but then you weren't able to generalize it much. Our program really focuses on that holistic approach that we can generalize, and that's why we pair it with mindfulness from cognitive behavioral therapy. So we're building not only via these exercises a body that's actually more resilient to insult on a physiological level, down to your vascular structure, but we're also building psychological resilience so that when we have hard times in our life, like we're going to, that we have the skills to meet up face front.
So let's take some of the components apart, because a lot of people, a lot of parents will ask me, oh, should my son or daughter do biofeedback? Or he's already working with a psychologist or psychotherapist for CBT. How is biofeedback with somebody else going to help? Could you explain what biofeedback is and maybe how that's different from neurofeedback? Because I hear people, oh, there's a neurofeedback program. Should I do that?
Is that cool?
Yeah.
You. Part of my job is to run the broader clinic. So the mind body part, we totally relate to. We're like a mind first group, and then we do skills interventions and psychological interventions around the mind. The mind and body feel very interrelated in the work we do. So I just wanted to start there. The second thing is we don't do neurofeedback. I don't. A lot of people do neurofeedback. It's been around for decades. The overlapping principle is that there's a feedback loop, right? So you either engage in some behavior or have some physiological response, or you have some like EEG response. And then, so EEG is more for the neurofeedback, biofeedback is more physiological, but something's either happening in your body and your mind that you capture with a device, and it gives you feedback through like a video, a tool, something, you know, how you did, a game. The younger you are, the more gamified. The older you are, the more metacognitive and self-aware. Anyway, we do biofeedback because, at least from our perspective, there's like a really rich and foundational evidence base there. And it's also not really contested. And I think neurofeedback, there is a lot of evidence, and it's also sometimes contested. And it's just not a space. Our group tries to only do things that are 100% sort of ivory tower evidence-based and uncontested. It's just our brand. So that's why we don't necessarily do a lot of neurofeedback, but neurofeedback does help a lot of people. Anecdotally, I've heard that. I've seen studies that show it's effective. It's just not something we deliver. We focus more on biofeedback because it's a little more of a traditional intervention that actually intersects with other evidence-based treatments. So biofeedback can work with CBT in conjunction. And just one last comment, CBT is like cognitive behavioral intervention without the biophysical tools. So biofeedback is going to capture your physiological response, your heart rate, how much you might sweat, how you breathe, things you may or may not be aware of in the office when you do CBT. It brings it to your awareness through feedback on your biophysiological symptoms because you get a response from the device. And if you use that plus CBT skills training together, you might have a more enriched treatment would be the idea, especially if you have biophysiological symptoms related to anxiety, pain, you know, concussions, head injury, headaches that kind of are mind-based, but also affect the body, and stress affects both. CBT is a nice approach, and then biofeedback has a nice approach too that's more physiological, and the combination would capture both. That's what we're trying to do. Sorry, that was a long answer. I'll let you speak more to what like biofeedback's really about and what you do in the intervention. But I wanted to distinguish it, and I appreciate the question, from neurofeedback, which is a totally legitimate tool that, again, there's a lot of studies on it. It's just not something we provide in our group specifically.
Got it.
Sorry, it was a lot. So
No,
okay.
well said, well said.
You know, for people who don't understand what CBT, cognitive behavioral therapy, I mean, there are a lot of people trained, a lot of therapists trained in CBT, different from other psychoanalytic therapy. And a lot of people use a psychotherapeutic model within CBT, so nothing is pure DBT. Could you explain what CBT is within your model?
Okay, let me try one too. I'll try to do that shorter. The way I see it is like a quick crash course on like psychology. There's like a Freudian model, and then Aaron Beck came out and did like cognitive, or there's like a behavioral model coming out of Penn and psychology, and a cognitive model. And there's like behavioral learning theory, like classical conditioning, operant conditioning. This was all happening. You know, there was already a Freudian sort of couch-based sort of, as the cliche therapy. Then there's a behavioral change therapy. And then Aaron Beck had a cognitive therapy on top. And then they became like cognitive behavioral. And that became sort of I would say like 10 or 20 years ago, it was like the thing everyone in an ivory tower evidence-based place was supporting. I think the pendulum always shifts, and there's more acceptance of other therapies and treatments. And probably what's happened is CBT has been broadened then. So there was like a pure behavioral, a pure cognitive therapy, a combined approach, and then an openness to the idea that a lot of therapies can work. And CBT became like, I think, an acronym for evidence-based interventions that can be studied a little bit, that have some cognitive and behavioral element. And so CBT, someone who does that now, is doing something cognitive and behavioral with some evidence base, but it's become a very broad term, I think. Because that's my perception of the evolution.
It might be an oversimplification, but one of the great parts about CBT, it's very focused. It's very much what thoughts and what behaviors are not serving you. Great, let's create a plan to correct that. Would you say that's a?
Yeah, it's pretty, there's a pragmatic component, I think, to a lot of CBTs. But again, CBT is expanded. There's like trauma-focused CBT. There's all sorts of, again, from my perspective, a little sometimes in and out of it. I think it became the thing to do. And so CBT became like something people come back to when they want to build their programs as a CBT model. There was like a Freudian wave, a behavioral wave, a cognitive wave, a CBT wave. Now there's like an acceptance and commitment wave that's sort of adjacent to CBT, which is a little more Eastern traditionally, and DBT is closer to that, like accept what is, commit to a valued life, but you don't have to change your thoughts, you know? So cognitive behavioral therapy is sometimes like, let's stop that automatic thought and make a change. And acceptance-based therapies are like, I'm having a thought that makes me nervous, that's okay, and I'm still gonna commit to the life that I care about. So that's another sort of movement on top. I think that's probably a little newer, for lack of a better word, in this evolution than CBT, but that it's closely related to CBT. And some people would say ACT or these treatments are CBT treatments.
And this third wave CBT that Lev's talking about, we actually draw on that within our biofeedback model within the CBT, because we include a lot of these skills are acceptance, especially because a lot of the kids we work with, a lot of the adults we work with have chronic pain. So acceptance, as well as those more meditative like mindfulness skills.
So, and this is not a question that you are both trained in, clinical psychology and biofeedback. How do you, I think of neuropsychologists as doing neuropsychological testing. You obviously, you know how to do that. That's what you're trained in. But how does that, there are very few neuropsychologists that also do intervention based on understanding one's neural pathways and strengths and weaknesses, etc. How do you incorporate all of that? Who should send their kids to you? Like, what kind of patient would you think would benefit?
I mean, we're a lifespan program, I would just say first. And like, and some of these programs with biofeedback and CBT work really well with adults too. So I just want to clarify that. By training, I'm a pediatric neuropsychologist, so I see people like 2 to 39. I mean, 39, I'm technically a kid, but you get what I mean. And then the person who co-runs the clinic sees adults. So we do lifespan neuropsychology. And as far as like how we found ourselves here, I would say, all neuropsychologists are licensed psychologists. So we do get broad-based training in therapy. And then some people have actually, you'd be surprised, a decent amount of neuropsychologists have very small therapy practices because we miss treatment as part of it, just from like a human perspective. Like, we do all these assessments, you want to be in the journey with some people, you know, you have the skill set, we were trained in it, and some of us have done more of it. So I do see some people doing, often evidence-based, fairly discrete treatments, because if you're a neuropsychologist, you're doing these discrete assessments and often not a lot of like long-term therapy per se, but there are some people who do that. We found ourselves centered on brain because we're just like hardcore neuropsychologists. So everything's kind of built around that. So if we're going to do a treatment, it's going to be like cognitive rehab or biofeedback with CBT. We don't really do therapy in the traditional sense in isolation here. We see people who have something that affects the brain or mind and also affects their feeling and behavior. And we're well positioned to treat that because we fully appreciate the mind. And that's a huge component to these profiles, the mind body. How that all relates, we have, as neuropsychologists, a neurophysiological understanding of what's happening in someone's mind and body that is a nice window into how you would treat. And so the idea is, what treatments can we effectively do that are closely related to our domain of expertise around neuropsych assessments? And I think that takes the form of the things we're actually doing, which is, we do some educational intervention, we do cog rehab, we do some dementia care, and we do lifespan neuropsych assessment. And biofeedback works well because it's a discrete, technical, scientific tool that you can connect to another discrete intervention for a practical outcome for someone who may have like concussions, to say concussions, headaches, like fatigue syndromes, things that are like sometimes anxiety driven, sometimes pain driven, and sometimes clearly a bodily impact or all overlapping, is a really nice place for us to apply this intervention, because we're getting at the mind and body like cognitively through CBT therapies and behaviorally through the biofeedback intervention directly. Does that make sense? And that's where, like, neither one of us would do couch therapy and do long-term, probably relational therapy, because we just don't have the experience or skill set. But when we talk about these sort of brain-based modular interventions, they lend themselves well to the work we do.
Right. Can you give an example of like how you might use biofeedback within working with a patient? Let's say a 13-year-old.
Of course, and I'll give a little bit of
He's got a
backstory.
concussion and he's got headaches, and you've done some neuropsych. He feels like his brain isn't quite working as it used to. Can you
Lonnie, that's right up my aisle, and especially working in concussion at University of Florida, I worked with students, I worked with the athletes, I worked with the general population, and we continue to see these individuals come through with concussion and the sequelae that, you see POTS, you see individuals with migraine syndromes, headache syndromes that they just can't break through. And it was so frustrating to repeatedly see them go to their physicians and be told, oh, it's just anxiety. Oh, like you just have to like get over it. And biofeedback really gives us an opportunity to kind of fix things on a physiological level. And just to a little bit of background, and I'll try to keep it brief. But whenever we're stressed, whether it's a physiological stress or a psychological stress, it affects our autonomic nervous system. Now, the autonomic nervous system, I don't know if you're all familiar with it, but it's kind of the system that runs from our brain to all these organs in our body, and it communicates both ways. And the more we learn that just because something occurs in one part of your body doesn't mean that it's going to affect everything else to a certain extent. So with that said, we have these three types of autonomic kind of pathways, but we're going to talk about two. We're going to talk about the sympathetic, which you've probably heard about. This is kind of like that fight, flight, or freeze. And then we also have the parasympathetic. I like to think parachute, like slow you down, because that's where you rest and relax. So when we're in these stressful situations, it's really important for our body. They're kind of two forces pushing against each other, that if we're getting chased by a lion, that our sympathetic nervous system is going to be able to take over, our deep brain structures take over, and our blood leaves our extremities, our heart rate goes up, our breathing changes, and that's very important for when we have to work really quickly. However, our day-to-day, where we might have chronic pain, where we might have a headache syndrome, we might be chronically stressed and thinking about something that's going to happen 3 Tuesdays from now, that really wears down on the body and creates what we call allostatic load. It breaks everything down. And when that happens, we're supposed to most of the time be in kind of parasympathetic, mode. But when that happens, we're shifted. We're always being chased by that lion. So with these individuals that have the concussion, right off the bat concussion and more severe brain injuries is really where the literature is established, but we see some autonomic dysfunction where you see more of that sympathetic control. Headache syndrome and POTS and all these other components, again, we see more of that sympathetic control. Now, what's unique again with biofeedback is we're actually able to harness something that's really available to all of us that's able to change that dynamic. And we borrow this from ancient India, some like the yogi practices, but that's deep breathing. And it's really fascinating. And again, I most appreciate, I think, again, in these situations where we feel like we don't have control, that something as simple as breathing helps us regain that control and put ourselves back into more of a homeostasis or, more of that rest and relax so our bodies can heal. And that's really, so with this program, an individual would come in, we would do the biofeedback, start with that bottom up. And again, we would connect them to all these little gadgets. We'd put a temperature sensor on their finger, because again, when you're getting chased by the lion, all your blood's gonna go to your stomach and your organs, main organs. Your breathing's gonna change. So we have a diaphragmatic belt that goes around, so we can look at diaphragmatic breathing, and that's a whole story in itself. And we'll look at, sweaty palms, some electroconductance on your palms, among a couple of other measures, including carbon dioxide, that changes with input and output. But we look at these measures, and it's really eye-opening for these kids and adults as well, because again, a lot of us are out of sync with our bodies. So having a visual picture of what's going on in our body really helps us understand, like, wow, I have this response and my entire body changes. And then we build on top of that by integrating the cognitive behavioral therapy, the mindfulness part. So again, we first build that mind-body awareness, and then we layer that with cognitive behavioral therapy, and we teach these different skills to help kind of better manage stressful situations, learn to accept these stressful situations. So you kind of have that break in moment to implement these skills we've learned. So they really work synergistically and really well, especially with individuals who are wary of therapy, who may not have a lot of therapeutic experience. Or I know I'm one of these people that tends to experience their symptoms through their bodies, because we all do to a certain extent. So it's a really fascinating interplay that we're really excited about.
Yeah, just to add one thing, the awareness of the data for, I think, young adults and adults who don't have as much access to their feelings and how it affects them is really powerful. And it becomes like a quantified data point that you can then like see and track for people who want that kind of approach more. I mean, for kids, biofeedback is used a lot too. Although if you go very young, biofeedback is used for like, this is sort of a pivot, but like constipation actually. It's used for like, things like, so there's like a very childlike biofeedback. And then I think what the type we're talking about is almost like an adolescent, maybe late childhood, but sort of someone who has some ability to benefit from like an intervention like CBT that without a lot of parent training, which tends to be like 8 to 12 at a minimum. I find like if you had a really young kid, even if we had this kind of intervention, they wouldn't have the sort of awareness to use it. So I just wanted to clarify that this is an intervention for kids, but you're really looking for someone who has some ability to bring their mind somewhat independently to it. So you're kind of looking at really more like 12 and up, ideally, for kind of intervention. And really the sweet spot is probably more like 16 and up, because there's a lot of awareness and insight you get from it. Does that make sense? So it can be used across the field, but and again, if you go really young, biofeedback has a totally different literature if you look into it, which is more around like activities of daily living and basic life skills. So anyway.
Yeah, no, that makes perfect sense. And I'm picturing, so you're hooking up a kid to, various sensors to look at autonomic control in a variety of ways. How do you get them to be able to, especially a kid with ADHD who has trouble maybe sustained attention, concentrating, and obviously quiet rooms, so there's less distraction, but you have all these inputs. How do you not overwhelm them with what's changing where? Can you kind of describe that?
Yeah, we tend to progressively build up because it can be really distracting. A lot of people are like really like they're entertained because it's very novel.
Right.
It can be overwhelming to have all these pieces on. So we'll usually start with like the breathing band. We'll look at like the mechanics of their breathing, because there's different ways that best optimize your use of your lung space. We'll build up based on their comfort level. Things like the nasal cannula, the look at carbon dioxide can be really like funky feeling. But luckily, again, our primary training is clinical psychology, so we're very good at building up progressively.
So you don't just attach all these monitors all at once
And then hang them out the window so they
No.
get the fear.
Yeah. People hear neuro and I think some people actually have more of a wish for this like really scientific, because you see it in a lay audience, you think like this futuristic, there's all these sensors, they're going to put me in the scanner. Then you come and it's like a nice office and you're sitting on a couch, and it's a stone's throw from how you'd feel in a therapy or a skills office. But I get your point. Some of the tech is a little more intrusive and the feedback is pretty salient to get on yourself, but that's part of the idea. You're trying to move people through an awareness like intervention with a little more acceleration, so they know how their body and mind connect. So yeah, Steve, we actually have, this is a little outside my scope, Sarah may know this, but we have like modules for different conditions. So there are discrete evidence-based modules that you would take someone through depending on the presentation. So there's like a migraine one, there's a concussion one, there's like I don't know, there's a few others, but the idea being this really is an evidence-based literature that you want to apply in a discrete amount of time. It's not like long-standing therapy. It's going to be a handful of sessions for a targeted presentation. It won't cover everything in your life. It is mind and body, but it's mind-body targeted to the presented concern in a somewhat time-limited way, so it's manageable. Does that make sense? Just to get back to your original question of a kid who has ADHD and is expansive, you want to have a targeted presentation. I don't think biofeedback as a tool is going to be super direct at treating the core symptoms of ADHD, for example. But someone who has ADHD as a component of their profile and a condition that's more discreetly treatable by biofeedback with CBT, we could apply that well to it.
That's actually an interesting piece out with ADHD is that part of the parasympathetic control is the frontal lobes. And that's really important in ADHD, planning and organizing. And that's, again, why when you have someone with a pain condition with that discrepancy in parasympathetic control, as you see poor emotional regulation, worse working memory, worse executive skills. So it is something that they've used in some ADHD. It's not going to fix ADHD because that doesn't exist. But it might actually help with some of those frontal lobe control and building that mindfulness that a lot of kids with ADHD really struggle with.
So if there is a kid, I'm thinking of one particular kid just as an example, 16 years old, ADHD, none of the ADHD meds because he's also anxious, have, his heart rate goes way up. And so they're trying to find the right, but he clearly has ADHD, difficulty causing, he's very smart, and he's got irritable bowel syndrome, he's been worked up by gastro, but he has horrible stomach pains, especially when he's stressed. So if he came to you, would you do neuropsych testing first before you then worked on a treatment plan?
That's a good question. I think in that case, there's a pretty discrete referral question. So we don't usually recommend a full neuropsych assessment if there's a clear treatment that would be meaningful, right? On a national level, there's more response to intervention, which is make a really informed, qualitative kind of guess, but really impression of what's going on, provide the most reasonable intervention, see how someone responds to that intervention, which then informs the assessment. So in places like, LA and New York, and honestly, generally high SES communities, people want to assess everything first. But I would say if you had a discrete question like that, you wouldn't really do a neuropsych for that necessarily. Now, if that same client had a lot of other layers, like we're wondering how the ADHD impacts it or not, we're wondering how much anxiety is relevant or not, we're wondering if there's a co-occurring learning difference that's undercutting at school and making them anxious, and then you start to be like, oh, that should be a neuropsych assessment because we need to parse the treatment factors and prioritize them. But if we already know that and we kind of have a good read on the client and they don't need a report for accommodations or some other purpose, you should probably just go straight to the most evidence-based treatment that would work. And again, really not to knock down neuropsychs too much, but if you look at a lot of conditions, at least on a group level, even things like dyslexia, most evidence says if you see a specific reading or writing challenge, and if there's family history, the value of the assessment is not that big. You need to start the early literacy intervention. So this is true across areas. If you know what you need to deal with it, and you probably don't need to do more assessment. But if there's complexity and layering, or we wonder if there is, then we would assess first. Did that answer your question? Yeah.
No, that's actually very helpful. And I'm thinking of, in very simplistic terms, you have kids who have more of a creative arts type brain who can picture things and they're into art and drawing and, good, vivid imagination. And then you have the robotics, physics, mathematical mind kid, who may be neurodiverse, maybe not. And I'm thinking of when you would incorporate mindfulness, for example, how do you decide how you tailor based on your clinical assessment of the kid?
Right.
Well, within the biofeedback model, it's we have it kind of set up to complement what we're working on and what we're actually measuring. So a lot of this, again, we could tailor it to the individual and we would maybe turn in a little bit depending on what they need. But are they someone that needs to practice more acceptance? Are they someone that needs more diffusion from an idea? Are they someone who would really benefit from, discussing these automatic thoughts? We're not doing a full CBT. It's more so focused on the mindfulness aspects. But again, we have the training, so we might pull it in if we think it's relevant.
Yeah, on a slightly more macro level, because some of these interventions are fairly systematic and modular. And so it's more about like the non-specific skills you bring as a clinician and how you relate and then tailor like the landing of the pitch basically. But I think to get at your question, we do a lot of treatment planning based on, which is really neurodevelopmental style, which is now called neurodivergence. You know, there's sort of a sense of differentness, but really we all have some style as a sort of totally non-pathologized way to think about it in either direction. And when you know that, that does inform intervention. So someone who's like more math, logic, science, and systematic is probably going to appreciate a systematic intervention more that's highly structured and predictable. And they'll take to it more and they'll feel anchored by it. Now, that might be the best to help them through something. You can make a counterpoint for that kid that they should be in an environment that pushes them in their areas of challenge adaptively, but not too much, and actually make it more open-ended. But that's sort of right. So you can, and then the same is true for someone who's more open-ended. You could create a more like constructivist conceptual model where you like talk about it and you like get insights, but it's not like as data driven or anchored in some chain sequence of A to Z or 1 to 10, you know, or you can make the case, you know, it really anchor this person to make it systematic and it's a useful skill for them to learn to be a little more systematic. So we're going to do this intervention this way on purpose. But there's usually an intent. If you do a neuropsych, there's usually an intentionality to every intervention that is sort of informed a little by the collaboration between the neuropsych and the treatment provider. Because if you have the luxury of 500 data points about how someone thinks, of course, you know, in every intervention, you're going to want to try to use those. And I think that's beyond assessment, care coordination is sort of where neuropsych might be heading, because like we don't need a neuropsych to know where your brain injury is. You put someone in a scanner, you know, but you do need a neuropsych to know someone's functional level across different areas in a nuanced way. And that can tailor skills interventions. Probably a little more than pharmacologic interventions, which are a little more diagnostic and binary. But when you're talking about nuance and how you frame it to a kid, definitely, yeah.
So this kid with abdominal pain, which clearly we know that irritable bowel syndrome or functional abdominal pain, where the gastroenterologist has done the thorough workup and the kid still has severe abdominal pain, hurts when he eats, and it's and for many kids gets in the way of going to school. And we know this is a brain gut autonomic dysregulation. So how in the biofeedback part would you address that?
It would again be a focus on these different indicators that are associated with like the sympathetic load. So it would be pretty similar for each individual. Like Lev was saying, it's like fairly modular. We may potentially, because biofeedback, one of the original uses was in IBS. We may potentially be able to tailor it more so.
Yeah, but I think what we're trying to do in this intervention is bring a quantified awareness to your biophysiological symptoms. And then through doing so, some self-regulation. And so the idea, I think that's the intervention and the goals aren't going to be that different probably than someone who's just doing CBT. But the access point is we have an extra tool, which is that we have a quantified read of the biophysiology, and then we can implement an intervention like deep breathing and see the biophysiology resolve. And if that's the mediating effect that like kind of triggers the IBS, then you've got at it. Now, you're probably still doing that in CBT, but you don't have as much direct access to, does the CBT actually manage these arousal levels? So you just have like more clarity of awareness of how you're delivering your intervention. But there's not something more specific necessarily that at least we do in our biofeedback. We're kind of applying the same quantified biofeedback lens to different conditions with really smaller tweaks based on literature, not like fundamental tweaks based on the condition. So the driving intervention is like biofeedback with CBT. It can be applied to kind of any mind-body condition fairly similarly with smaller adjustments, is at least our delivery of the approach. And that might be partly because we're not like specialists specifically in IBS or specific, you know, right? So like concussion,
Yeah,
we might get a little more.
they're autonomic dysregulations.
Right. But probably concussion, we're going to be a little more specific, truthfully, our program, just because we're such experts in concussion. But that's a function of our skill set, not necessarily like the how widely biofeedback can be applied or how specifically to IBS. It's a good question. Yeah. If you ask us a question that basically, if IBS, part of what's hard for neuropsychs is we know some about it, truthfully, but it's not a primary condition we're as exposed to as like headaches, concussion, migraines, because for whatever reason, as they're defined, people see those as mind first. And so we were taught those more. I mean, it's really probably a function of that, not that it's really one way or the other. But I think to answer your question, part of why we don't have probably a richer response specifically of how to tailor it to IBS is probably because we just don't do a ton of IBS. And maybe maybe I'm learning we should, but anyway, it's a helpful discussion for us. So thanks for asking. Yeah.
And so one question that parents all ask, well, my kid goes to your program and has his session. Is there homework? What do you expect the kid to do between sessions?
Yeah. I mean, generally, we're talking about skills training. I'm going to give a macro answer, and then Sarah will give the specific one if that's okay. But any skills intervention you learn through procedural practice. Okay, like if you think about anything you've taught or learned, first you get a lesson or you go to a class, then you practice like shooting the basketball or swimming, and usually the coach is quiet, and then they debrief with you after. And there's a reason that actually works, which is when you're talking to someone, it's more explicit and it's an awareness. And when you're trying to learn something, you can take that awareness with you. But any skill or habit you're unconscious of, like how well you drive or how effectively you walk, like those things you're not thinking about if you're doing them well. You're thinking of where you're driving, but not how to do the action. And so the way our brain learns those is through repeated like practice the same way. It's actually not an awareness of how to do it. It's a body feeling of how to do it. So if we're talking about a skills practice, yes, you're going to need to practice at home for it to be more effective, because anytime you reliably practice, you're building that skill or habit. And then sometimes we need to we use parents to apply it. So once the skill and muscle is bigger in training, then you need to make sure it's applied in the right setting. And you often need parents or other agents of change to kind of cue the person who's developing the skill to use it. So practice is important, and an application of the skill in the context that matters in your life. Those are both really important, and parents often, for kids, help us with that a lot. Yeah. Sorry, that was a
perfect response.
Okay, fine. Sorry. Yeah, but go ahead.
Yes, there's brief homework. Yes. And like Lev's saying, it's very important to have that practice, because you're not practicing this. You're not every time that you're using this tool, you're not going to be in our office. You're going to be at home. You're going to be at school. You're going to be in acute pain. You may be having like an orthostatic episode. So we want this to be practiced so well that it's a skill they can draw upon when they're in periods of distress.
No, that's helpful. And of course, there's always the balance between the teen wanting to do that on his own and being motivated, which obviously you work on, versus the parent, kid was going to do it until the parent said, you got to do it, and then forget it.
Well, that dyadic cycle, just since you mentioned it, it doesn't help kids launch. I mean, it's hard to deal with. But if the parent cares more than the kid in adolescence, they experience it as nagging and pestering, and that's actually the lesser issue. The bigger issue is you relieve the adolescent or young adult of the responsibility to own their issue and move through it. If you care about it so much more, you're pestering them. And then they actually, I find over time, don't develop as much ownership, agency, or effectiveness. And then when they get older, they actually want their parent to help, but they're regressed. So just to name it, there needs to be somewhere for the kid to step into. Even if that step isn't as big as the parent would want, unless it's a crisis, and then of course you step in for them. But otherwise, there needs to be some arc in adolescence and young adulthood. Otherwise, the outcomes are just, I see what happens to these young adults. It's not a good trajectory. If that it hurts the parental-child relationship, it undercuts trust, all the things. If it worked in some way, I would advocate for it. It kind of doesn't. It just saves the day in the moment to get the kid to practice one more time, but it has a lot of consequences otherwise. So you really have to have a model where there's some engagement in adolescence. I find for most interventions to really work effectively and not just in the near term, there has to be, and some people use motivational interviewing or some Socratic methods or some methods to make sure we're not dictating to an adolescent what to do, because that's against the grain of most adolescent development, to be told what to do by people. So it's normal for them not to want to be told what to do. We have to embrace that and find a way to still be effective. It's a great point. Anyway, I see that a lot, and it's frustrating because everyone knows what needs to happen, but we're stymied by a dyadic kind of dynamic that's very hard to change because it's so entrenched usually when that's happening. And like the parent feels like they have to do more and more because the kid does less and less, and the parent does more and more, and the kid does less and less. And there's got to be some break in that loop. And whoever's working with that family, that's really important, as it relates to this work. Yeah.
Are there tools that the kid can have at home iPhone or other mechanical tools to practice with?
Some of these tools like are a little prohibitive expensive, but not many. Like some of these you can send home, they're like $100 devices. You know, they could, if they were in our treatment, we'd send it home with them, but they're like consumer products that you can extend. The office-based tech tends to be a little more robust and a little price prohibitive. Maybe it's 20 to 40 grand. People aren't buying that for a biofeedback intervention for themselves at home. It's really for a clinic model. But those
Right.
are all being scaled down into devices, which will continue to happen. And then because it's paired with CBT, you can do the same practice at home, even if you don't have all the sensors. You just won't have as rich of a biofeedback loop. But that's okay. Just like if you went to see a physical therapist, they have more tech there. You go home and do your exercises. The model's not terribly different. And then if you wanted an at-home model, there's at least a few things like heart rate, and I think there's a few others that you can get. But breathing, like some of that stuff is more of a bigger device in the office.
Right.
Yeah,
Right.
yeah, good question.
What about sound in this process? Is there any value in having either white noise or just a quiet room, or how does auditory input impact what you're doing?
I think it partly depends on the kid, but there's probably a more specific answer for head injury that like Sarah's much better at me at. So let me I'll do the general, then you should talk about that. Because if there's not an injury, and you're talking about neurodivergence, some people need more input and some people need less input. So I want to be really careful about how to answer that question, right? So, and you often know, like, does the person with white noise or background noise, does that settle them? Or does more auditory stimulation unnerve them? And does it matter if it's meaningful with language or pragmatic with like melody or just background noise? Like that actually varies by person which is just a mind style thing. I think that's gonna neurodevelopment is so driving that unless there's a massive injury, the answer is partly going to be what's the neurodevelopmental answer. That's why I gave that. And depending on the injury, there might be a more specific answer. Like probably with brain injury, usually you don't want as much input, especially in the near term. But maybe you could speak to that, Sarah. Like I could be wrong.
Again, it really depends on the
Yeah.
individual. While phonophobia or, kind of that sensitivity to sound can be a common symptom after a concussion, it isn't necessarily present for everyone. It's really like what reduces barriers, what helps you focus the best, what soothes you the best. So again, very person-centered.
Mm-hmm. And I guess, is there any advantage for an adolescent to doing some of this in a group as opposed to individually, especially for practice at home?
I mean, groups are really neat. There's a lot of powerful change. You learn there's community building, normalization, change, motivation, and especially for young adults and adolescents, they can be really effective. There's also variables you can't control as much because there's a lot of people in the room. So I think I guess it depends a little bit. I think some of the tech, the way it's hooked up, is designed to be delivered somewhat individually, like the biofeedback. But the skills and the practice definitely could be group based. I mean, Sarah's doing a prehab group, which is like how to have executive skills preparation. Like there's impact testing for concussion, which is kind of like, let me get a baseline if my kid's on like the football team or lacrosse. So just in case there's a concussion, we can do another test and make sure. That's assessment based on return to play. But part of what we're also doing is an executive skills prehab group to basically have the skills and be ready. So if you do have an injury that affects your mind, body, and your efficiency, you have the structure beneath it or some backdrop course to rely on. It's more of a prophylactic, type of intervention or idea. But anyway, that's another idea we're trying to work on with groups. I think the healthier, it depends. The more you can get group cohesion, or on some ways, the more there's healthier resource, groups can work really well. If a lot of kids are really impacted and need a lot of support, sometimes groups can be destabilizing. So it depends a little bit on those factors, I would say.
Especially with some of the mindfulness where they're really trying to focus and focus on internally, which is not an easy skill. So I could see a group being kind of distracting.
Yeah,
actually.
potentially. Yeah. It depends on what they're doing. But if they're working on some reframing or some application of a skill, or I don't know.
But do we have an evidence-based answer? No.
Yeah, thank you for that, Sarah. Yeah. But groups otherwise, again, in general, you scale care, you provide greater access and you increase engagement, motivation, you normalize things because you're with other people. There's a reason groups really work. I mean, so I think the idea is nice. It just depends, again, how much individual support and how much of is it an individual experience partly to move through this treatment. Then you might share it with others, almost like a support group model, like I use these tools. What did you use? Oh, I did that. Oh, that's neat. I'm going to try that later. But you might not be able to practice it together because of the nature of the intervention. Yeah. Good question.
Maybe like a refresher afterwards, like almost because again, a lot of these skills are taken from yoga practices.
Right.
So it could be something that maybe even on a Zoom call, you all get together and do deep breathing together just as a practice to stay fresh.
Yeah, there's something, I think part of why that answer is a little, where I'm like at least conceptually struggling a little with it, is the nature of the biofeedback is so quantified and so precise and so individual that there's something about it, and also a neuropsych assessment that's true. So we often find ourselves in like very precise places that don't lend themselves to like a group model as well. So I think that's part of the intervention, is like it's supposed to be so tailored to you, which causes some friction about doing that with the group fully, unless you pull out a little bit and work on the skills that everyone learned and that they can share together.
Yeah. For initial skill learning, definitely looking within.
I'm reading a question from a participant. I have a 13-year-old daughter who was diagnosed with AMS, amplified pain syndrome, almost a year ago by her rheumatologist, and POTS last week by her cardiologist. We've been given guidance on different interventions to use. I'm having trouble getting her to go to her appointments lately because she said they never help. And we hear this all the time. We are on our third psychologist, and it doesn't really seem like CBT is helping. She suffers from chronic leg and back pain and constant migraines. Could biofeedback be a better fit for her? And how do you find experts in your area?
Great question. That's a tough one. I have a couple ideas I just want to be like humble and honest. We do know a lot of things. I'm not a specific expert in POTS, right? So in some of these conditions, so I want to qualify.
POTS is
okay.
Autonomic nervous system out of whack.
Fair enough. Yeah. But you know, we do see some clients. I'm familiar. My concern to offer biofeedback as the next solution here is there's a story in this particular like qualitative anecdote of like not some non-responsiveness to treatment for whatever reason. And so one more outpatient treatment might not be the fix. Sometimes in these cases, when you have like 2 or 3 people, if you think they were solid and you didn't get traction and it's sort of getting worse and you got another, sometimes those models, it's best to go to a center where they really specialize this, in my experience, do some wraparound care and get everything calmed and focused and kind of contained. And they're also going to be experts in these things because they're like often at academic medical centers where they're known for it, and they'll know people in the area and how to kind of place back out. Now, that might be too high level of a care, and I'm not specifically making any recommendation, to be clear, based just on an academic note, but I wanted to share in my experience, when you have, if you've tried CBT once, it didn't work, or twice, okay, but if things are getting slightly worse and they're not responding to treatment more, you sometimes, rather than just another outpatient treatment, you actually want to up the level of care and get more people seeing the person all at once at the same time. And that, I guess that's sort of more my answer for this type of profile, but it doesn't mean, that's not to say biofeedback couldn't really help, and it could potentially be a better fit, but it's possible this type of profile is going to need a little more where all the doctors meet together. Because again, sometimes you can have really great doctors, but it's like a lot of fiefdoms and everyone knows their area, but there's just not a forum for them to communicate. And there's, truthfully, just to be frank, there's no billable model for that. There's no like time built in for that. So whether you're an insurance practice or a cash pay practice, unless you prioritize it fundamentally in your work, which we do try to do, but it's hard to do, you know? So when, again, there's complexity and multiple layers and non-responsiveness to treatment, we usually recommend more of a wraparound approach, even if it's outpatient, so we can all get our heads together and kind of calm the system and then build back to like maybe biofeedback would be a good outpatient treatment to revisit. It's a great question. I hope that was, thank you, Lonnie. I know that's more your domain of expertise. I'm just sort of, when let's say 10% of the cases I see or 5% are adjacent to this. And in my experience, the outcomes are best, again, usually when we kind of have a real specialist and a group all working together. So there can be a great outpatient cardiologist and a great this and this, but if the team doesn't really know this and they're not working together, something will either be missed or there'll be lost transfer of information. And, you know, it's really important to kind of get everyone lockstep, the more unique the situation. So then you can self-advocate and orient your providers going forward from a place of real knowledge and power, not asking your providers and not really knowing. You know, so go to the source of experts, And maybe that means you have to move, go somewhere briefly for a period. And then you really know it, you're subject matter expert, so you can better self-advocate and navigate a more general therapy market that might not know as much about your unique profile. That's true regardless of the unique profile. I find that's an effective strategy. Yeah. Cool.
No, I like your descriptions in your model, because a lot of what we see, and not just what I see in our chronic pain clinic, but others internationally, you often have with pain, whether it's post-concussion, headache pain, migraines, etc. Usually there are other body parts that begin to hurt because either kids aren't moving or they're not, and then it just a layer of other things. They're stressed. If they have ADHD and they're missing school, then school becomes a stressor, etc. And I like your approach of, the system is neurologically out of balance, and your aim, whatever, is getting things back in balance and using mind and body in this connected way. And for kids that need that physical reinforcement to see that they're actually changing things, they're changing their respiratory pattern or their heart rate, that's very important as validation that what they're doing with their brain is actually changing their body, and likewise. And so, I think your concept of what you're doing, I would say, applies to all kids who have anxiety, chronic pain, if they're neurodiverse. I mean, and it's a model that I think we all do, and I want to highlight the communication piece. Certainly, that's a critical part where you have everybody. Otherwise, it's like the blind man and the elephant. So you have the neurologist doing these meds for migraines, somebody else, rheumatologist, and it's, different parts of the body, but nobody is coordinating care. So that, I just want to commend you on that model, which I think is critical. I want to thank our two experts for just a fabulous and informative discussion. Know that this has been videotaped. It will be on our YouTube channel and people will be watching it afterwards. And I want to thank and donations. I'm supposed to keep remembering everything we do is free, so people don't have to pay to do this, but if you can, donations, $25, whatever, are welcome.